And I promise I'll try to make it short and stick to the half an hour. And my name is Safa Eltayeb. I'm a consultant cardiology based in Dammam. I decided to keep my talk talking about the cardiac risk assessment instead of actually spreading it to the cardiovascular, meaning I'm not going to impose on the cerebral, the peripheral, and the mesenteric circulation, although they do go hand in hand with that. We know it's quite fair to talk about diabetes and cardiac diseases as two sides of the same coin. Because diabetics at some point in time in their life, they are going to develop some cardiac complication or a arteriovascular complication, and the vice versa. Those who present with cardiovascular event or a cardiac disease, they either present with a full-blown hyperglycemia, or they're going to develop it sometime down the road. So they both are the same end of the spectrum. It doesn't matter where the patient starts, they're going to bump into one or the other end at some point. So the treatment of both is quite important. Now, I'm sure this has been seen time and time again, and what I would like to emphasize is this point. Okay. Try to do that right. Okay. What is important is this bit. Okay. Right. Okay. So this is a bad news. 8 out of 10 diabetics are going to die of a cardiovascular complication. They're not going to die of diabetes. They're not going to die of renal failure. They're going to endure a lifetime renal dysfunction, but they're going to die of a cardiac event. The very good news is it's in our hands and in our domain to prevent it or to slow down this risk. And that's what I'm going to try to emphasize, raising the flag high for prevention rather than the treatment, because treatment is extremely expensive and it is not 100% life-saving. Now, I'm going to assume that each and every single one of us in this room is seeing patients day in, day out. So we do run clinics, we receive patients in the wards. So the first question that we need to ask ourselves when we see a diabetic patient in our clinic, what is the chance of this patient to have a near future event of a cardiac disease? Let's say cardiac. Number one, I want to emphasize, I'm not going to talk about type 1 diabetes. The talk when we say diabetes is mostly type 2 diabetes. And when we talk about these patients, we're talking about asymptomatic patients. Please know that patients who come with symptoms, irrespective of cardiac, peripheral, arterial, or cerebral, these patients have actually decided their algorithm. They go for intervention, force with and maximum treatment. This is a group of patients we're not going to discuss. This is a very difficult group of patients who are going to take ages for us to finish. And this is what we face day in, day out. I'm trying to emphasize the importance of because this is the rest of the iceberg. What we see is the tip of the iceberg. The rest of the iceberg are those group of patients whom we see. Now, a patient who is diabetic coming into our clinic, the first question we need to ask, what is the risk this patient is having? The mere fact that the patient is diabetic is, to start with, he has a moderate risk. And then we can build up based on that, whether this patient moderate risk is actually a higher risk or even a severely higher risk. The moderate risk patient is a very ideal patient that I'm sure we don't get to see most of the time, because he is a young patient below 50 and he has diabetes for less than 10 years with no end organ damage, no diabetes, no hypertension. He doesn't smoke, he is exercising, and he is lean. Hey, this is a very ideal patient. What is the chances that we are going to see this patient? What is the ratio of this typical patient in our practice? Very minimal. The message I'm trying to get is the moderate risk patients are the very, very minority. Those we get to see are those who have diabetes, and I'm sure the previous speakers have explained, and we know that by the time we read a high blood sugar, be it fasting, be it random, that the process of transition into hyperglycemia and the metabolic process have been going for the last 5 to 10 years. The problem is it's not happening only in the pancreas level or at the cellular level. It is affecting each and every single organ. And this is why patients who come with ACS, acute coronary syndrome, might be started that they have a blood sugar of 200 or 300 and, hey, doctor, I'm not diabetic, this is a wrong reading. No, this is a natural history of a diabetes as it eats away all our internal organs. And it just, your luck, you presented with this complication. The point I'm trying to say is the moderate risk patients are the minority. Most of the patients we see day in and day out are diabetics who have high blood pressure, who have a degree of renal impairment in the form of microalbuminuria, who smoke, who have sedentary life and a body mass index of more than 35. Each and every single one of those features immediately escalate the patient risk from moderate to high. And if you want to go from high to higher, which is a very high risk, it's a very, very minor things like left ventricular hypertrophy, like the presence of calcium score of more than 400, like the presence of an intimal thickening on the carotid, and we don't have to hear a bruit. By the time we hear a bruit, the stenosis is actually more than 50%. And we know if the stenosis is more than 90%, there is no bruit. Absence of bruit is not absence of carotid stenosis. So most of the patients, unfortunately, we get to see are the high-risk patients or the very high-risk patients. The asymptomatic, those who come just for the clinic. What do we do about this patient? How are we going to assess if this patient going to have an event soon or otherwise? So what are the tests available to tell us which is which? Let's start by biomarkers, a test that we tick. We just get in the computer and we tell the patient to go to the lab to get his blood tested. What are you going to choose? C-reactive protein? Now, C-reactive protein is an inflammatory test that I know it can go up, especially the high sensitivity C-reactive protein. It can go up in the presence of an active plaque, irrespective of where that plaque is, cerebral, cardiac, or peripheral. But it has not been found that there is an actual correlation between the C-reactive protein and the future, near future, or distant future of events. So this is out. We don't need to check the C-reactive protein. What about the famous serum troponin? This is my pain as a cardiologist. I'm telling you, we are overusing serum troponin. We are treating the troponin of the patient. Each and every single patient who comes with each and every minor symptom, get the troponin checked. If you go and see the reasons why a patient troponin check, you will go through 2 or 3 pages. There is a percentage of normal people out there, they have normal troponin. So for a patient who has no symptoms, we are not justified to check the serum troponin because we will end up treating the serum troponin, not the patient, and that does not reflect on the patient's long-term survival. What about the famous pro-BNP or BNP for heart failure? Now, diabetes is a very aggressive disease. We know it is sometimes equal to malignancy, if I may say. There is a syndrome called diabetic cardiomyopathy, and that is irrespective of the presence or absence of coronary artery disease. And this is part of the active inflammatory process. The way it happens in the kidney, it happens on the heart. And that might reflect, because it's an infiltrative process, because it's a fibrotic process, it can reflect on a high level of BMP. But again, high levels of BMP does not mean we're going. So if the patient came in, we checked his BMP, and the patient is asymptomatic, I am not justified to go and get the patient to all the way for angiogram to look at into his coronaries. What I'm saying is neither of these is actually found to reflect on the patient's long-term outcome. But here comes a gold, the albuminuria. A previous speaker who spoke about albuminuria as a very good marker for deterioration of kidney function, and I'm raising the flag for it as a cardiovascular. The only proven test that is actually reflecting on the cardiovascular outcome is albuminuria, and that should be looked for passionately. If there is one test that I would have to ask for this patient who comes to me as a cardiologist for the first time, which is unlikely because most of them, they actually come after complications, I have to look for albuminuria because that will make a 180-degree difference in his prognosis and his management plan, and obviously in his risk assessment. ECG. Do we do ECG for each and every single patient who has diabetes who come into the clinic? Should we? Right. Before we do that, as part of, at least that's what we learned in our medical school days, if a patient has diabetes, the examination on the bedside, you should assess the heart rate, because sinus tachycardia is an ominous sign. You should check the patient's ability to raise the heart rate or blood pressure with hand pumping, and we do that day in, day out when we do a dobutamine stress echo. If we want to get the patient to the target heart rate, we get the patient, if he gets to the maximum dose of dobutamine, to actually lean on his left side and start pumping the hands for more than 1 minute. And if he managed or she managed to raise his heart rate, that's a good sign. Failure to do that is one of the signs of autonomic dysfunction. A patient who has a resting heart rate of more than 100 is bad news. And I'm sure you see this constantly in diabetic patients, especially type 1 diabetes. The single most fierce enemy in diabetics is tachycardia. The resting heart rate should not exceed on average more than 85. Alarms should be there if it is more than 100, and it is significantly correlated to sudden cardiac death, and that is mostly because of ventricular arrhythmias. Despite it's an atrial tachycardia, but it is having to do with ventricular arrhythmia because of one simple fact. It means there is denervation of the heart, and denervation of the heart is one of the things that actually predispose to the development of ventricular arrhythmia. So if the patient has sinus tachycardia, yes, get him an ECG. If the patient has high blood pressure, get him an ECG. I'm talking about the asymptomatic patient, time and time again. Asymptomatic patient. Again, we talked about the low heart variability or failure of the heart rate response to go up. The artificial intelligence of each and every single ECG machine will give you all these details without having to calculate it. You don't have to know the formula to get the corrected QT interval. But this is again correlated well to sudden cardiac death. Females usually have a longer QT interval compared to males, but whatever the sex, if the patient who has diabetes, the QT interval is more than 480 milliseconds, you should start getting worried. This is an ominous sign, and this is one of the predictors of sudden cardiac death. Again, this is handed to you by the ECG in artificial intelligence. You don't have to exercise much of the work to do to get there. ECG, we know it can miss a lot of things, and if it gave you ST changes, there are lots of things. Gallbladder disease can give you T-wave inversion. Cerebellar or supratentorial hemorrhage can give you this abnormal T-wave inversion. So they are non-specific. This is why we should revert to exercising the patient. However, exercise on the treadmill specifically should be combined in these patients with imaging modality. So the best way to exercise those patients, as you can see, most of the guidelines are telling you to deviate or to go away from treadmill testing because of the high false positives and false negatives. So what you do is actually you combine the exercise with imaging. So exercise the patient on the bicycle using the echo, or use the dobutamine to stress him, or better still, send him to the cardiac MRI for better assessment. Now, if there is only one thing that I want to talk about, my next slide is going to talk about the role of imaging, the three imaging modalities, which are the echo, cardiac MRI, and CT. What we want is this particular part. It's technical issue where?
In the other laptop.
But it's working fine?
Yeah, no. It's back.
Yeah.
Yeah. You want the pointer?
Yes.
Yeah, next pointer.
Okay.
Yeah.
It works for you only for some reason. Anyway. Oh, we'll just ignore it. The subclinical remodeling, this is the significant part, and this is the part that worries us. Those patients, they just don't go into those things out of the blue. You know, the process of myocardial injury is not only because of the ischemia. The hyperglycemia itself, it exerts a lot of effects. Part of it is ongoing inflammation, and that's where the money is. And that's probably part of the reasons why the SGLT2 inhibitors work on the heart, because they attack that part, the inflammation phase on the myocardium. And this is why imaging is no longer about ejection fraction. It's no longer about the presence or absence of forward motion abnormalities. It is about more sophisticated ways of picking abnormalities, echo, and cardiac MRI on a CT, probably by using the three of them to pinpoint out who is a patient who is at risk of having a second event very soon. Let's start by the gold standard, the most available, the widely available. It's a bedside and it's used in an in. It's a very strong tool, but however, just like anything, it is in the hand of whoever is using it. The problem is the inter-observer variability. For echo, we look at the left ventricle. There are 17 segments. Those who know how to read the echo, there are 17 segments. The left ventricle is divided into 17 segments. We have to, if you get a request that this is a patient with diabetes and we want to assess his LV function, I should make a point of looking at each and every single segment, how it contracts, how it relaxes, and if there is any abnormality. And this is how I detect on echo how these patients are going into an early thing. We calculate the mass, we calculate the function of the left atrium itself, and the deformation, the failure of the left ventricle to relapse. These are technical details that might take forever to get into, and we might discuss it after the talk got interesting. Anyway, echo findings, they are important because they have good correlation with hospitalization and death from cardiac complications. But the gold standard is this day and age is the cardiac MRI. Now, as part of how we assess the response in heart failure for SGLT2 inhibitors, both the EMPA and the DAPA, in Glasgow Royal Infirmary, which is, let me say, it's where most of the heart failure studies have actually evolved and were born. They used the cardiac MR to assess the response to the treatment, looking at certain parameters, mostly the decrease in the LV size. So this is how we know that the effect of SGLT2 inhibition is beyond blood sugar control, is beyond diuretic control, is beyond weight reduction, but is actually at the cellular level, because we could see that on cardiac MRI. Now, without going into the details of how cardiac MRI can work in these patients, or how would you see it is available, and it's a future trend for studying cardiac mortality and morbidity and prevention in these group of patients. Cardiac MR is, wherever you read, they will tell you it's in infancy, it's still expensive. We proudly run cardiac MR services in both Al-Mani at the MAM and Al-Mani Al-Khobar, day in, day out. Next test, the CT, the most available. Now, for the CT, there are pros and cons. Diabetics, like renal failure patients, have higher degree of calcification compared to the rest of the population. So it's good to pick the calcification on the coronaries in these patients, but you have to read them properly. It's not about the number, meaning the 400 is the number 3 calcium score of 400. We know it equates to higher mortality. But remember, the calcification we see, it happens on the plaque because it has a lot of adipose tissue. But if there is a lot of plaque and a thick fibrous tissue, this plaque is very stable. The score of calcium does not address the vulnerability of the plaque. It will not tell us if this plaque is going to rupture or not. As a matter of fact, the plaque that's going to rupture and give us the next event has less calcification. There is a lot of inflammation. So this is why coronary calcium score does not always mean ischemia. But if we saw a calcium score which is high, we can send the patient for assessment of ischemia. For example, if you saw a lot of calcium on the LAD territory, left anterior descending territory, and the patient is asymptomatic, but he is a smoker, he has moderate renal impairment, he has, for example, very uncontrolled lipids, we can refer this patient not for angiogram, but for assessment of ischemia in the territory of the left anterior descending. So identification of the presence of a significant coronary stenosis has not been shown to be superior to aggressive medical treatment for cardiovascular risk factors. And I think this is the most important message by all means. This is, again, remember, we're not going to test the patient randomly. This is to highlight the only +1 B and C for those patients is checking albuminuria again and again, and resting ECG in patients who are higher risk. The rest are 2A and 2B. No need for C-reactive protein, no need for BMP, no need for troponin. These do not mean a thing. Okay. How are we going to prevent it? Now we've got the patient, we classified him as moderate to high risk. We know his score, we obviously investigated him. How are we going to prevent the occurrence of coronary artery disease? And that's where the money is. Al-wasaya al-ashr. Number 1, lifestyle modification. Number 2, glycemic control. Number 3, blood pressure control. please observe the interaction and the overlap between the heart, prevention and management, and the kidney. Number 4, lipid level management. Number 5, not only glucose control, but glucose lowering medications choice. It has to be very particular. On these, I am actually referring to the ESC guidelines 2019, which is not yet updated, but it is still the 2019 guidelines, European Society of Cardiology and Diabetes. And this is one of the very, very few non-cardiac diseases that has been endorsed by European Society of Cardiology, just reflecting the overlap between the two diseases. So continuing with the 10 commands, acute and chronic coronary artery disease management, coronary revascularization, treatment of heart failure and prevention of heart failure, last but not the least, is management of arrhythmias. I'm going to mention only those which are class 1A, and the previous speaker had made my job easier by literally talking about most, if not all of these. I will just have to add few bits and pieces. Smoking cessation, as we all know, and we keep telling, it's a very important part of lifestyle modification, but it doesn't work. Smokers might stop for a while and they come back because we do it wrongly. The guidelines will tell us it has to be structured advice. There has to be dedicated and designated smoking cessation clinics. It's an art, it's a science. It's not like stop smoking and and he goes, no. There has to be a function, there has to be a plan, and that has to be structured, planned by designated and very well educated and trained personnel. Lifestyle intervention, and when I say intervention, I have to refer to bariatric surgery as an emerging role in most of the international guidelines to reduce the body weight, improve glycemic control, improve blood pressure control, and sometimes it reverse glycemia or stop actually diabetes development. It's not out of cosmetic issues. There are many patients who have obesity and have heart failure. And when we refer them for higher centers, for example, for CRT or any device, the patients are told to lose weight, and believe me, in many patients, the LV function improves and they go above the 40%, which is a cutoff line for an implantable cardioverter defibrillator insertion. Exercise. I cannot overemphasize the importance of exercise for each and every single person, not patient, every single person. I'm not going to ask the very famous question of who in this room goes for regular exercise or gym. But I will tell you a story of one of my acquaintances who works in one of the international societies, and she was kind of putting on weight. And she has been noted, it's part of the renewal of the contract to do the weight and the body mass index. So her weight went up and the body mass index went up, and she was suspended for 3 months from renewal of contract. And she was asked to go for stringent exercise, and she was actually noted by not you go to exercise on your own, but you have to attend our classes, that particular institute. And if she failed to attend to one of them, she will be reported. So only when she attended her base ideal body mass index, then her contract was renewed. I'm just wondering if we started adopting this policy in our hospital, who would fail to get the renewal of the contract? Anyway, it's just a thought. Now, second, it's a recommendations for glycemic control in patients with diabetes. Now, before we go there are a few things about glycemic control. A 1% reduction in hemoglobin A1C is rewarded by a 15% relative risk reduction for fatal MI. So it's not a joke. We have to do it to prevent patients getting into MI. That is our job. Now, Hemoglobin A1C recommended to apply is about 7%, but we are invited to go lower to even 6% in subgroup of patients. For example, young patients with new onset diabetes who got a long life ahead to them, we are compelled to reduce their hemoglobin A1C to below 7%. Elderly who are above 70, they are at risk of hypoglycemia. We can actually be more lenient and more allowing with them, and they can go on an average hemoglobin A1C of above 8%. Not only that, and I'm sure the previous speakers have evolved into that, and we all know that in this day and age, to get an FDA approval of an oral hypoglycemic, it has to have a cardiovascular protection. But we know that hemoglobin A1C does not reflect the diurnal variation of, or the day in, day out variation of postprandial versus fasting blood sugar, because that itself can reflect on mortality, meaning a drug that can give you a very nice fasting blood sugar, but fails to give you a good 2-hour postprandial blood sugar control is not a good enough drug. And in this day and age, we have all the armamentarium and tools of measuring the average blood sugar per day. And shortly, we are going to see the FDA approval for the drug that proves the consistency of blood sugar control throughout the day, not the variable that goes up and down. One word about hypoglycemia. From the cardiac point of view, remember hypoglycemia is one of the risk factors for ventricular arrhythmias. And the sudden cardiac death because of hypoglycemic event is not only because of the cognitive effect of hypoglycemic coma, but because of the long-term and the immediate consequences on the heart. Blood pressure management, we know that the best target for these patients, or the best, is a combination of renin inhibition in these patients. One word about the use of beta blockers. In the good old days, beta blockers were absolute contraindication for heart failure, absolute contraindication for diabetes, absolute contraindication. There is no absolute contraindication. It is who is the patient with diabetes who needs a beta blocker. It's not an absolute contraindication. Definitely, it should not be the first choice in a patient who is diabetic, because of we still have a diabetogenic effect. But if the patient is diabetic and have degree of LV dysfunction or sinus tachycardia or any arrhythmia, we're compelled to start beta blocker. Full stop. If you are to choose one of the beta blockers, let me tell you that nebivolol and carvedilol are the drugs that have less impact on glycemic variation and has better control on or effect on insulin sensitivity. Dyslipidemia, وما أدراك ما dyslipidemia. Now we've heard a lot about it, and I just want to emphasize that 1 millimole reduction in LDL is rewarded by a 20% reduction in all-cause mortality cardiac-wise. Full stop. It is not an option. It is a must. We have to do it. A patient who has uncontrolled, and we don't have to remember all these numbers. The lower, the better. There is one problem, that the patients are comparing their LDL to what we have in terms of what is there written in the laboratory. We have to go and revise our laboratory numbers because the numbers are not correct. We have to go lower, and it's in everybody's capacity to go and review those numbers, but it usually should be less than 1.7 or less than 1.5 or 4 for patients who have a previous events. First choice is a statin. There is a very big thing about the statin. Yes, there is a chance of inducing diabetes. It is said that in the more diabetogenic statins, 1 millimole reduction of LDL, despite the fact it confers 20% reduction in cause mortalities, but there is about 5 to 7% increased chance of developing diabetes. But this did not prevent millions of statins prescriptions every day worldwide, is it? No. Okay. Now, it's not only about glucose lowering, it's about the choice of medications. Now, I'm not going to overemphasize the fact that we have to use medications that are proven to improve cardiovascular mortality, and we're talking about those which are class 1A, class 1B, which are the SGLT2 inhibitors and GLP-1, full stop. Now, patients who have ischemic heart disease, this is an indication for lifelong treatment with ARB or ACE. This is for protection. In the good old days, when those trials started, the most famous or the most commonly used was ramipril and perindopril. But this is actually probably is a marginal superiority of those two drugs, and we are to use any of the ACE or ARB for protection. Antiplatelets. It is to stop by worldwide practice that patients who do not have an evidence of coronary artery disease or peripheral vessel disease as a prophylactic primary prevention using aspirin is class 3. It should not be used. This is history. This is long buried. Aspirin should be used for those who had a previous event, cardiac, peripheral, whatever. But sustained use of aspirin to protect is not evidence-based. Even for those who have very high chance of developing ischemic heart disease or other peripheral diseases class 2B, meaning it's still soft next to 3. Revascularization go along the same lines, cabbage or bypass. We prefer to use the lima because it has more durability compared to the radial, compared to gastroepithelial. It's an artery that has been created by Allah subhanahu wa ta'ala for cardiac surgeons to use for bypass. This is a busy slide. It just tells you that when a patient with diabetes develops heart failure, we go on the same lines using the 4 pillars: renal inhibition, beta blockers, MRA inhibition, and SGLT2. This is exactly what it says. One more added is if the patient needs a device. This is not to treat heart failure only, but this is to prevent heart failure. And this is a major breakthrough in the prevention program in diabetes. SGLT2 inhibitors are there to protect the myocardium from going into failure, and that is on the cellular level, and it happens before the patient loses weight. It happens irrespective of the reduction of their blood sugar. So, in asymptomatic patients, the key message is to stringently reduce blood sugar, blood pressure, lipids, and improve other effects, and that is enough to decrease cardiovascular events by 75%. Fascinating, isn't it? But look at the downside. The multifactorial treatment is still underused. Why? It's our fault. It's our inertia. It's a physician inertia. And the best way to conclude this slide is what has been said by Al-Khobar al-Mutanabbi, وَمَا رَأَيْتُ فِي النَّاسِ عَيِّبًا كَنَقْصِ الْقَادِرِينَ عَلَى التَّمَامِ. Thank you very much for your time.
Thank you, Dr. Safa, for this superb presentation about cardiology and diabetes. I'd like to express my deep thanks for Dr. Safa, for Dr. Sameh, and for Dr. Abir, and I think all of you now waiting